Welcome, everybody. This is our cardiothoracic surgery professional community town hall meeting. As most of you are aware, Alex unfortunately had a surgical emergency. He's taking care of a very sick patient right now, had to go back to the operating room. So he just called me to ask me if I could take over for him, something that obviously I was happy to do. His presentation is on the screen right now. This is the agenda that was proposed. First, we'll be talking about the current structure and the incoming structure of the professional community. Leadership group, cardiothoracic surgery. We're gonna talk about membership statistics related to ISHLT. We will talk about the upcoming annual meeting of ISHLT in April at the Toronto Conventional Center in Canada. We will specifically review the pre-conference workshops that are available for everybody to attend. We're going to talk about symposium proposals. The guidelines are under development and webinar ideas. And at the end, we will have two very interesting talks about the topic of ERAS in lung transplantation by Dr. Caitlin Demarest. And that will be followed by a talk on ERAS for advanced heart failure patients with Dr. Kevin Lobdell. So this will be this is a current structure of our professional community right now. Alex Bernhardt is our leader. He is the PVD Interdisciplinary Network Steering Committee representative. He obviously is from Hamburg, Germany. Dr. Ivan Netuka is our representative from the Leadership Advisory Forum Institute. And he is from Prague in the Czech Republic. Dr. Kumara Sivathasan, he is also a representative from the Leadership Advisory Forum. He is from Singapore. Dr. Julia Reinband, she's the representative from the MCS Interdisciplinary Network, and she's from Vienna, Austria. Dr. Caitlin Demarest, she's the representative from the Early Career and Trainee ISHLT Committee, and she's from Vanderbilt University in Nashville, Tennessee, here in the US. My name is Ezequiel Molina. I'm a representative from the ISHLT in Espanol. I work at Piedmont in Atlanta, Georgia, in the US. Roxana Moyedifar, she is the representative from the Advanced Heart Failure and Transplant Interdisciplinary Network. She is from Vienna, Austria. And finally, Mauricio Villavicencio, he's the representative from the Advanced Lung Failure and Transplantation Interdisciplinary Network. He works at the Mayo Clinic in Rochester, Minnesota, in the US. In terms of general statistics for ISHLT and the professional communities, this is the breakdown. Majority of members come from two or three different important fields: cardiology, cardiothoracic surgery, and pulmonology. You can see the percentages: 28%, 23%, and 14%. But as we were discussing before we started the talk, our society is a true multidisciplinary organization with representation from many other fields, including nursing and allied health, pediatrics, research and immunology, anesthesiology, and many other fields. So a true representation from all components of our heart and lung failure medical fields. When we look at the 2025 demographics in terms of membership type or profession, the vast majority of members are physicians, 61%, non-physicians, 23%, trainees, 15%, and a small percentage of retired and emeritus members. When we look at regions, unfortunately, North America continues to dominate this. I think it's our job and goal in the next few years to expand representation from other continents as well. But for now, 74% of members are from North America, 15% from Europe, and then a smaller but important representation from South America, Asia, Middle East, and Oceania. I'm sure there are a few members from Africa is logged as 0%, but I can't believe it's just zero. I'm sure there are a few members there. And in terms of interdisciplinary networks, 51% of our members work at the Advanced Heart Failure and Transplantation IDN, 26% Advanced Lung Failure and Transplantation, 12% MCS, 3% Pulmonary Vascular Disease, and 8% other interdisciplinary networks. These are the meetings that will take place during ISHLT at Toronto. There are very well organized professional committee receptions. This is the schedule. You can see on the screen the different professional committees are meeting on April 23rd, which is a Thursday, and on April 24th, which is a Friday. Our cardiothoracic surgery PC meets on Thursday, 23rd. And there are also IDN meetings, and you can see the times and the locations on the screen. So hopefully we can all participate from these important meetings during the ISHLT meeting. And there are also, as always, very important pre-conference workshops that will run the day before the beginning of the annual meeting, on Tuesday, April 21st. You can see on the screen 5 important workshops. One is the 2026 ISHLT Action PHTS Advanced Cardiac Therapies in Congenital Heart Disease and Pediatrics Master Academy. There will be a 2026 ISHLT Thoracic Recovery course with a hands-on experience. We will repeat this year the 2026 Cardiogenic Shock Academy, which will have we will be running in real world cases, and we will have a simulation lab, and it will be very, very interesting. Hopefully we'll gain the attraction of people in the shock space. The 2026 ISHLT Trainee Workshop, which should be very, very interesting, and the 2026 ISHLT Infectious Disease Pharmacy Academy, which I think is a new workshop. So if you can, please try to advertise all these workshops on social media to attract as many candidates as possible to register for these important meetings. These are the professional community webinars that took place for the last 12 months or so. You can see that in terms of cardiothoracic surgery, we had 2 PC webinars, one back in December 2nd with 87 total registrants, 22 people on live attendance, and then 127 YouTube views. And then we had our second event webinar on February 3rd, and we had 80 registrants total, and we have to update the numbers. I'm not sure if Juliet has those numbers right now to share with the group or not.
I will put it in the chat.
Okay, fantastic. Thank you, Juliet. So I think we can obviously continue working to make these webinars very attractive and try to attract even more people. I think that the field across the globe is really large, and I'm sure we can, using the right tools, we can probably aim at attracting even more attendance than the ones you're seeing on the screen. So those are all the slides that I have for our PC activities and demographics for our society. We will follow next with two great talks about the important topic of ERAS. We will start with Caitlin Demarest from Vanderbilt. She will talk to us about the great job their team at Vanderbilt has done applying ERAS to lung transplant recipients.
Okay, thank you. I'm going to share my screen real quick. Okay, let's see here. Okay, you guys see this?
Yes, thank you.
All right, I'm going to briefly go through kind of two different slide decks. So I'm at Vanderbilt, as we said. I'm a lung transplant surgeon and the associate surgical director of the program. And we recently, me and one anesthesiologist decided to do a formal ERAS pathway for lung transplantation, try to expedite their care and hospitalization and improve outcomes. And so I didn't even realize when I got into this what a really involved and formal process it is, at least here at Vanderbilt. And it was really kind of awesome. So I stole some slides like from the ERAS people that I'll show you. We all kind of know what ERAS is, right? Decrease length of stay, decrease complications, patients do much better. There's lots of data. The hospitals save money, patients do better, it helps everybody. So at Vandy, they have ERAS programs like most institutions and many, many different specialties. And then the newest one is for lung transplant. And this process started here in June 2024. So it took, a year. It took a little over a year to get the ERAS protocol in place. All right. This just shows like a one kind of screenshot that's a dashboard that we log into at any point, and it has our compliance listed for every single little piece of our ERAS protocol. And this is like an example of what it would look like for the ERAS protocol and how compliant you are and how good you're doing at a month-by-month basis. And then so this is complicated, but this is the process you have to make this ERAS pathway. And so first thing was we had an introduction with the kind of leaders from each group. And so it was me as like the surgeon champion. There was somebody from pulmonary, from anesthesia, from IT to do all of the builds in Epic, from rehab, from the APPs, like stakeholders in every different area to meet and decide what our goals are. And then we had meetings we had meetings every week for a few months. We had the weekly development meeting, and the whole ERS team met every single week for an hour to decide what we wanted to do from every single step, from when the patients are at home to when they first get called in for the lung transplant, when they're in the pre-op area, when they're like every single step was broken down. And we discussed what we can do in each different step to improve patient outcomes. And then once we had kind of all of the pathways set of the ideas of what we wanted to do, then we started meeting more monthly as the IT people worked on their build. And then the ERAS team also met with not only the whole group at once, but would have smaller meetings with just the surgeons or just the pulmonologist or just the APPs or just the pre-op area. Or the ICU was really important too, right? To get the ICU on board with the different things we're going to change with the post-op care of these patients. And all of this stuff, again, it's really too complicated to go through all of it, but this is like how detailed it was, doing every single of the 7 milestones. Every single milestone was really kind of thoughtfully constructed. And we went live with it in September, and so it was like a year and 3 months that it took to go live from the time that we first started the process. Here's like another example of how we just met monthly and then went through each milestone and went live. And then like the champion, with the work that went into create this protocol. So during the development, the kind of the champion from each team, they wanted each of us to have like an hour or two a week, because it was like the one meeting a week where we reviewed and refined the process. And so all of us met, once a week during that process for like basically like that year. We had to do literature reviews like define what the clinical care components were going to be, what the specific pathways we wanted, to break down into the phases of care, the pre-op, intra-op, post-op phases, and even break them down even further. Make the order sets to make everything smoothly for pre-op and post-op. And then build the dashboard where we can log in and review the dashboard at any time to see how we're doing. It can spit out like the patient outcome differences that we're making insofar as length of stay, intubation time, tracheostomy rates, everything. We can see it all in this amazing dashboard. And then now that we're live, we're meeting like once a month. And each month we are reviewing the dashboard, like seeing if there are complaints, if anybody has issues, if there have been any hiccups. Like the meeting this past week, there were like a few hiccups in like the pre-op order set with like heparin and trying to get it, trying to sort that out, and when to hold the anticoagulations. Like little things had to be kind of refined. And so we're doing that monthly now that we're live with this. It's just an example of, or basically this lists all of the whole team. And so the primary, you have a champion from the surgery, pulmonary, anesthesia. Then we have ones from the ICU. We have surgery APPs, anesthesia APPs, and then the IT people, even everyone kind of responsible for building it. And then all of these people from all these different teams join our meetings and have to give their input into the ERS protocol. So peri-op, people from peri-op, also like the scrub techs and circulators joined because maybe different instruments that we're using. It was really important to educate the circulators in the OR about like the specimens, and making sure that everything is streamlined. Physical therapy, rehab, we changed some of those protocols. So having them involved in this process, like really involves everybody in this process from start to finish. And then let me show you this other one kind of just quickly. So this again, kind of just an overview, so now that we're live, we kind of review all of this. So each month we say, are there any changes we should make to this? How are we doing with our pre-op optimization? We have this high-rise anesthesia. It's like a high-risk anesthesia clinic. So all these patients go to high-rise clinic and they see pre-op nutrition and get a nutrition pack. And like we reviewed last week, like how's this going? We made a landing pad for the patients. And so previously they would usually go to the CVICU, like to the bed they were going to have post-op, but sometimes there's not a bed clean or a bed ready. And so we wanted to make like a landing pad where when lung, we did a lot of lung transplants last year, 149. So there's a lot going on all the time. And so having a space where we know the lung transplant patient is going to go is like a really nice thing. So we have a standard landing pad room the lung transplant patient goes to, and the nurses there are educated about what to do for pre-lung transplantation. We also standardized like the pre-op and intra-op processes. We got, we have a low threshold to use inhaled nitric oxide. So we got a special nitric oxide generator in the operating room, and each patient gets their own kind of nitric oxide machine. So we can have it, because we used to have to wait a while to get the nitric oxide, and it was a barrier to the ERS protocol. So we got special, got capital buy-in from the institution to get additional devices to have in each OR to be able to use for each patient. We also, have been working obviously at attempting to extubate earlier. We tried to extubate in the operating room when we can after a double lung transplant. And so we put an epidural before the surgery starts for all of our ERS patients, which are most patients unless they're kind of bridged to transplant. We do intra-op cryoablation as part of that, and added a whole bunch of different multimodal pain management regimens that are managed by the anesthesia and the pain teams also, who all like kind of voted on this of what the best way to do this. We, on the surgeon side, we are doing less invasive techniques and smaller drains to allow for better physical therapy, more mobilization. We try to keep even, teeny tiny incisions when we're able to, and try always to spare the sternum when we can to improve their mobility afterwards. And then, in the meetings we review how our metrics are we sticking to the protocol, and what barriers are there to being successful. Um, let's see. This is just some about more about the process and, let's see what else. So this is talking about the admission process. So the things that, again, that we reviewed to kind of refine last week, was admitting patients to the landing pad. If there's not a landing pad bed available, then they would go to this other location, which that happens occasionally. We updated the pre-op order set because there were some hiccups with that. We have our patients not get heparin because we give an epidural, and the heparin was still in the pre-op order set. So a couple of the ERS patients got the heparin because it was part of the order set, and then they couldn't get their epidural. And so we went back and refined that after that happened a couple of times and changed the pre-op order set again to take the heparin out entirely. And then this is kind of the checklist, and everybody has this. So like the surgical fellows, we have it, the nurses in the pre-op area, patient gets to the bed. What do? Call thoracic surgery, call ALDS, who's the pulmonary team, place the lab test. These are all the things that should be ordered every single time. Notify the fellows, like if anything's abnormal or any of the swabs are positive, and all of this stuff that's for the nurse to be able to do this checklist every time so that things don't get missed. And then day of surgery, we have this stuff kind of posted around. So pre-op epidural placement by anesthesia. We use standardized central line placement. We double stick the IJ so that the MAC and the swan can be removed very soon. They could just have the triple lumen left behind. We use a TEG to guide blood management, anticoagulation. The respiratory equipment process I had mentioned before, we have the nitric oxide machine in every OR now to make that more expedited. We use cryoablation which we think minimizes post-op pain. We use smaller incisions and smaller drains. We're having a lot of issues with I'm sure like a lot of people, getting specimens to the right place. Some go to path, some go to culture. And so we really try to standardize the intra-op specimen collection process to make sure that nothing was ever missed. Let's see, I had to go back. So we went back and changed all of the, like for the ERS people to capture this stuff, specifically the intraoperative things. Like, was it minis? Was it thoracotomies? Was it a clamshell? And did we do cryoablation? And did we end up giving heparin for some reason? We usually do ECMO and no heparin. But to have all of that be able to track, I built a new op note where each thing's a drop down, right? So the incision's a drop down. It's like a mini or a thoracotomy or a clamshell. And heparin, yes, no, is a drop down. And dose is a drop down. Same thing with cryoablation, so that when they can be easily captured by the dashboard, and you can see like what our compliance is with trying to avoid bigger incisions, and what our compliance is with cryoablation and all of that kind of thing. It makes it very easy to track to make sure that we're sticking to our ERS protocol. Again, all this stuff is very in depth. The work that went behind everything. This is just an example of in the OR. This is just for like the respiratory therapist. And so what anesthesia and the circulators and respiratory has to do to get the patient their nitric oxide if they're using it, and everything's really detailed to make sure that nothing is missed. And this is so the circulators in the OR, right, for a lung transplant. These are some things you need to do differently. And so this is a checklist that's provided to the circulator in a lung transplant so they can make sure they have all of these things. Provide, notify the ICU this patient's coming, get that nitric oxide device in the OR in case we need it, set up an intra-op bronch, get ready to do the specimens. Well, this other little thing that came up was, we're trying to leave these little Blake drains and then to get the Plurivax gone and just have little bulbs. And like the connector, there was issue with the connectors, and the APPs are getting frustrated. It's like we have a note on here for the nurses to like tape the little drain connector to the atrium so the nurses and the APPs later, when they switch them out, they can connect them to the bulbs and make it easier. Again, just like making sure the ERS protocol is easy for everybody to do. But all these little details that come out of the kind of the woodwork is interesting as you're trying to do all of this. Let's see, this is about specimens. And that really, and then the ICU, they have their own, we have, a whole protocol for the ICU, use their, the pathways that we have, the order sets we have. Document if there's any reintubation, really carefully document, obviously, the reason for reintubation. Document PGD grading every single day. We do a post-op bronch on post-op day 7 for everybody to collect specimens. We had mobilization goals posted in the ICU for patients. They need to ambulate every single day. They have to be out of bed at least 3 times a day. We have patients wear a mask outside the room. We have all visitors wear masks. Also, then more of the drain, a lot of the drain management, really trying to expedite drain removal and keep making it easier for patients to get up and get around. So we expedited like how quickly we're getting all of our chest tubes and drains out also. Let's say, and then step down, same thing. So the step down unit, once they leave the ICU, that's where they go to the step down, and they have to, we specify patients have to be out of bed for all meals. They have to walk 3 times a day at least. And then the physical restrictions change based on the type of incision they have. And so we write all this down and have this posted in the ORs, in the step down rooms for patients, how much they can lift and how much physical activity they can do, whether or not they have a clamshell or just a mini incision. And then same, we had to teach all of the rehab, the physical therapists about sternal precautions. And, historically we did mostly clamshells. And so now we are, that had to re-educate the physical therapist that now patients with minis can really do much more than the patients with clamshells because there's less risk. And that's really all I had is kind of like where we are. Our lung transplant volumes like really increased. We had this interest in making an ERAS pathway. It went live in September. It's going pretty well. Each month we're kind of refining and finding more little things that we can make better. But really, trying to assess if patients' pain is better, if their time to extubation is better, if they're able to walk around more and get out of the hospital faster. And that's kind of all TBD, but I think it should be successful. And so that's just a whirlwind of how we started this ERAS lung transplant protocol here, Vandy.
Great. Thanks so much, Caitlin. I congratulate you and your team for taking on this new system. Clearly, it was about 1.5 years on the works, right? You started in June 2024 and you went live on September. So there was a lot of work for over a year before you could go live. If you had to think about what key advice you'd give to other programs who are interested in formalizing this system, what those key pieces of advice would be, you think?
Yeah, I mean, the biggest thing is, if like tapping into, I mean, I guess it's kind of obvious, but tapping into most institutions probably have ERAS committee or ERAS people that have made ERAS protocols for other, whether it's general surgery or colorectal or whatever other program has an ERAS protocol. So find out from them how they did it and is there already a committee that's formed. Like ours is already like very formalized. Once they had the idea, like they ran with it, and I just kind of did what I was told. So finding out how they organize the prior ERAS protocols, because then it makes it because once they have done it once, it's much easier to do again. So that's probably the most helpful thing that we did, was immediately involving all those people.
Okay, great. Any other questions from the group for Dr. Demarest? Maybe in the meantime, I can ask you what things you thought were not really possible to do, and after applying ERAS, now it became a reality at Vanderbilt, like doing most patients in a minimal invasive way or extubating people in the OR.
A lot of little things kind of in each phase. Like one, the landing pad, right? Like all the time, I'd be like, patients coming, like, where are they going? CVICU or no? There's no spot. Should we send them to pre-op? Then pre-op gets mad, like, oh my, like, and it was always like every day rewriting like the rules. And so now that the ERAS protocol kind of forced us to have a landing pad, that's really nice. Now there's like a designated like 2 beds that the pre-transplant patients go to, and the nurses are educated. That's like one really good thing that came out of it. Pre-op epidurals, that was kind of an idea of one of the anesthesiologists, and they're like, okay, yeah, let's do it. Irrespective of whether they're getting ECMO or heparin, like they all get an epidural, which is something that we hadn't previously done. And that was a big barrier here anyway, like post-op trying to get an epidural. Not everybody uses epidural, but like we would try to, and it was just a hassle trying to get one in post-op. So having it in intra-op, pre-op is really helpful. Also, the in-OR extubation, that wasn't something we were really doing before this, but like once we were kind of like, let's like go for this, really, let's pull out the breathing tube and see what happens, and usually it kind of goes okay. And then what else? And then really just having everybody educated because they're monitoring every single micro movement everybody's making. So making sure the nurses are educated. Magically, the specimens are going to the right places now, because people are being held accountable. So kind of a lot of different good things came out of it.
Fantastic. All right.
Yeah.
Congratulations again. Thanks for sharing your experience. Okay. Um, if there are no other questions for Dr. Demarest, we will move to our second talk. Our second speaker is Dr. Kevin Lobdell, who is a world expert on ERAS. He's a member of the ERAS Cardiac Society, and he's on the advisory board of that society, and he will share with us today his take on how ERAS can be, what principles of ERAS can be applied to advanced heart failure care. Dr. Lobdell?
Yeah, sounds great. I hope you can hear me, and I'm going to try to share this presentation. Bear with me as we try to do this. Are you able to see the slides?
Yes.
Okay, terrific.
You're not on a slideshow yet. You are on the regular. Maybe you can go through the presenter mode to make them bigger.
On mine it is, but is there a little delay?
Interesting.
I think we're seeing the speaker view.
Okay, let me try again.
Do you have two monitors?
There you
Yes,
go.
that's correct. There you go. Thank you.
Really didn't do anything different, but maybe it's catching up. Terrific. Caitlin did a great job. I think mine will complement hers. Maybe hers was a little bit tactical. Mine will be a little bit more strategic. And I say that she's younger, I'm older. I'm reflecting back. My first heart transplant was October of 1986 in Minneapolis at the University of Minnesota. So you're going to get a slightly different perspective here. I'm in Charlotte, and we've been at what we've called our quality improvement program for 20 years. And as you know, since say 2017, a lot of those elements overlap with what are known as ERAS. So think of early extubation, goal-directed therapy, that sort of thing, as well as the interdisciplinary team. How do you audit actions and leading key performance indicators and so forth? So again, I think what you'll hear is maybe a complementary perspective, maybe a little bit more strategic. Let me just see. This is not advancing. There we go. Like any interdisciplinary team, it's worthwhile to pause and thank all the people that participate. When I say that, all the great clinical care, teaching one another, helping one another. And in our case, it's pretty remarkable. I put my disclosures just so everybody knows where I'm coming from, and there's nothing that's really relevant with respect to this. And so what I'll do is focus on this ERAS cardiac perspective and try to focus people's attention on readiness. So a little less on the elements, but a little bit more on what does it mean to comply with these things to get our patients ready for things like early extubation or walking or getting ready for home. Then a little more specifically on temporary mechanical circulatory support and heart transplantation. And then the area of my passion, it fits into the element of patient engagement, but there's many facets, everything from patient-reported outcome measures to novel biometrics and so forth that help us transform the work that we're doing. So I'll describe that. So Fast Track Cardiac gets started in the 90s by Richard Engelman, Dan's father, and the ERAS more broadly started 2001, more in the general surgery, colorectal surgery, some in OBGYN and other areas. And then, as we all know, it tends to focus on the interdisciplinary care, multimodal elements, amalgamating the marginal gains. And, as Caitlin appropriately pointed out, we see fewer complications, shorter length of stay. There's some evidence at this point, depending on which study you look at, for mortality. And it sort of makes sense. The things that are more common, like complications you'll see before you see the effect on less common things like mortality. So I think this is the natural evolution. It's really been quite impactful. Our first publication on the guidelines in JAMA surgery 2019 ends up in the top 5 of ultrametric research scores, 99th percentile attention scores, incredible number of downloads and views. And I think I looked today and it had been cited 1,320 times or something like that. So there's a lot of interest in this area. And again, what we're really seeing is, and Caitlin pointed this out artfully, but it's worth reinforcing. Instead of the sort of traditional defensive medicine, ERAS really focuses on this active readiness. And in the patients with advanced heart failure, the 2 areas I think that are really important to focus on are like the prehabilitation and early mobilization, because prehab makes sure those frail patients come at the right time and are ready and helping work on things like frailty, and then early mobilization, where we have people that are, traditionally confined or they're tethered to devices. There's a lot of evidence now, if you do it in the right way, you can get people up moving and combat some of that catabolic process that often goes on. So again, I think it's important to think in terms of readiness as opposed to just the individual elements. So kind of pointing the same thing out, top left, prehab, bottom right, early mobilization are the things that I would really focus on in the advanced heart failure area. For those that haven't seen it, Current Opinions, we published something more generically in adult cardiac surgery, just talking about how to think about ERAS, how to focus on the key elements that are pertinent. And then in 2024, ERAS Cardiac Society, along with POCI, developed a series of 4 publications published in the Annals of Thoracic Surgery. And we had everything from an executive summary to best management practices, definitions, and then things like escalation, de-escalation in the temporary mechanical circulatory support. So it's good to know those things or have them in references. I think I always am hopeful that we'll have more concrete evidence, but I think getting people inspired to do the work, share the things that have the strongest recommendations, the greatest level of evidence is a start, and then the other ones will develop over time. I try to think of all of this in a little bit more comprehensive way than what we typically talk about in ERAS alone, but quadruple aim of better care, cheaper, affordable care, great patient experience, and then great clinician experience. And this is where I'll tease everybody or catalyze thought on things that we're working on. So since 2019, we've been remotely monitoring our adult cardiac surgery patients. We have a digital health kit that we track heart rate, sleep. We also give them blood pressure, cuff, and scale. And as you can imagine, with these novel sort of approaches, we have what I call a movie of their postoperative care. So we have a lot of touch points to be able to both engage them, educate them, and monitor and proactively manage things. We do that through our nurse navigators. And I presented this at STS this year. What we found with the series of investigations, we published 2023 on our coronaries, later in 2023, JTC VES Open on coronaries, valve, coronary plus valve. Subsequently, in that Annal short report, our first 1,000, and then the update here at the STS was the first consecutive 1,715 patients. What we've seen is shorter postoperative length of stay, about 40% fewer readmissions, and we now have 97.8% of our patients being discharged to home. I don't have to tell you, but that's all pretty remarkable. A like group might be in the 80-85% discharged to home. And so to do that with a 4.7% readmission rate and shaving a day off of contemporary propensity score matched controls is pretty remarkable. What we thought with respect to this, and this again, is kind of teasing people to think about things in a new way is, say in our 1,715 coronary plus valve, all comers, we only had one mortality. So it's time to start thinking way beyond death and these complications and patting ourselves on the back. We've come up with a patient-centered composite. And with that, what it means is you have no operative mortality, no major morbidity, short postoperative length of stay, you're discharged to home, and you're not readmitted within 30 days. And what we found when we looked at remote monitoring versus non-remote monitoring is you were 1.49 times as likely to achieve that composite. So it's really insight into digital transformation. We also then took out all the death and complications to just make sure that we were getting a pure look at remote monitoring, because there were some difference despite the fact that we matched them, and the odds ratio is still in favor of remote monitoring, 1.43. So it's really remarkable. And then I did some modeling based on benchmark data to look at the difference in the financial impact. And we see about a 7.5% difference if you include length of stay and the readmissions. That doesn't include the potential, which we've also quantified, but it's a little bit more ethereal, is the potential for growth. So if you look at a 500-bed hospital and the savings and so forth, you see that you can do somewhere in the area of 112 more cases and generate more revenue through that throughput. So we really think this is the way of the future. We've now got an experience over 3,200 patients, and we're spreading it throughout the 16 cardiac surgery programs within our system. We also have hospital at home, and this has supported a tremendous number of patients. This is more on the medical side, reduce costs, help with capacity, all the usual things, and particularly in some of our facilities in the more regional areas, it can help reach out to patients that are otherwise challenged geographically. Heart failure at home in general has shown that you can manage the majority of these patients in the outpatient setting. There's differences in survival. So I think there's good evidence in the literature that this is helpful. Quite frankly, what you see is the switch to proactivity. Other thing that I find pretty exciting is if you start taking, say, the digital biomarkers that I mentioned and consider things like ST2, GDF15, galactin-3, or whatever panel you're interested in, and you weave it in there, you can imagine even doing better than what we've done with just these digital biomarkers. So I think this is something we're going to have to weave into our pathways. And then the thing that we're most interested in, or most recently interested in, and just published in JAMA Open, is working with our clinicians for biometric monitoring and coaching for them. And what we found is reduced burnout, increased fulfillment, increase in their self-valuation. All that is a part of the Stanford Professional Fulfillment Index, and again, emphasizing things like the Maslach burnout scale. We've done better in all those areas. So in other words, when you're looking not just at your patient, but your interdisciplinary team, focusing on them, trying to make them stronger, more resilient, I think there's great potential. So we're continuing to work on that and trying to spread it throughout our system. So if you ask me, where do I think we go next with this in things like advanced heart failure, ERAS, cardiac, it's really how do we learn and improve together, and then having a very clear rubric for prioritization. So on the institutional learning, the thing that I'm working on are micro-learning modules, ERAS, cardiac. We're working first on a general. The next thing we're working on is SSI. The third is blood management. We'll go right through the high priorities like AKI, early extubation, that sort of thing. And again, I think all of this is good, but from a strategic standpoint, if you're in a busy institution like most of us are, you've got to figure out, what are the most impactful things? Where do you get some early victories and weave that into a standard prioritization scheme that's aligned with your strategic objectives? So with that, I thank you. I'll answer questions and see if I can't stop sharing here.
Great. Thanks so much, Kevin. That was a great summary of the great work you and the ERAS Cardiac Society have been doing throughout the last couple decades. Maybe I can start with a quick question. Obviously, we're all aware our ICUs, have many patients waiting on temporary MCS devices for either heart transplantation or a durable LVAD or decision making. And obviously, for most patients, there is like a window of opportunity, right, to transition to those therapies. And in an ideal world, we want everybody to be walking around, mobilized, optimized nutritionally. But the truth is that some of these patients are really sick. And, in the process of trying to optimize them as much as possible, some of them can lose candidacy for these therapies. They can develop a deadly infection from these invasive devices. They can develop a stroke or other complications. So my question to you is, how do you balance, getting the benefits from ERAS and not missing that window of opportunity to deliver that therapy?
Yeah, I think it's a great question. What you're talking about sort of generically is there's a U-shaped risk curve to most of these things, say like mobilization. There's more risk if you don't mobilize them. There's potential risk if it's too early or too frequent. And how do you find optimal? And what I would say is in each of those areas, whether it's early extubation or mobilization, there's a learning process. In fact, this just came up because there was a high-risk patient that we a couple of days ago did with Impact 5.5, or I should say Impella 5.5, and they were very proud, got him extubated, but I think it, quite frankly, was too early. The RV got in trouble, and now the patient's sort of what I would call being recycled. My advice to the team and the younger surgeon was have conversations and say it's important for us not to have these things happen. What can we do to learn and improve together? And what you're doing is you're demonstrating that you trust each other, you're transparent about things, you're having conversations about important things. In your after action review, you talk about what are you going to sustain, what are you going to improve, and then you make the next step. But the point there is that you're setting these common aspirational goals, you get aligned behind them, you learn together, you hold people accountable. And it's a lot different than the old, explain away the problem, or it's not my problem, it was the people in the unit. You really have to come together. You have to have these conversations. You have to eliminate unnecessary variation, which I think we heard Caitlin talk about too. And then what happens is everybody learns together, and you think, okay, we can extubate a little earlier, or we can move them along a little sooner. Or you might say, hey, what we learned about that patient is they were too frail, or they weren't quite ready, and we should have looked at an echo or something like that. So it's sort of a generic way of answering it, thinking in terms of optimal and thinking in terms of the whole interdisciplinary team and developing a shared mental model about these type things.
Great. Thank you. Anybody has any questions? Otherwise, I may just ask one final question, and we'll close there. My other question is maybe very specific. It's about mobilization on ECMO patients. Historically, ECMO patients have suffered from this approach to ECMO care, where patients are virtually immobilized since the moment they get cannulated until they get the next therapy. And that obviously is associated with high morbidity and mortality. And one of the big surprises that I received when I moved here to Piedmont, Atlanta, almost 4 years ago, was that they were walking ECMO patients. And that's why ECMO is our actual preferred temporary MCS strategy. And every patient who can walk, walks. And I think that's phenomenal. What is the position of the ERAS Cardiac Surgery Society on how to mobilize ECMO patients? Because I really feel like this should be more of a common approach rather than isolated centers doing this.
Yeah, couldn't agree more. And again, the proviso that it's got to be the right people at the right time in the right way. And, I would say figuratively or metaphorically, baby steps, right? You don't just go in one day and decide to pull the patient out of bed and walk, and nobody's used to it. You've got to get them to the side of the bed and make sure you've got lines secure and the right people around and that sort of thing. build some confidence and experience and then increase. I think that your point too in the best management practices in that set of 4 guidelines or expert consensus statements that we put in Annals, there'll be some more details for the audience that they could refer to. What I wish I could tell you in all of this is any one patient exactly what to do, how to do it, when to do it. Quite frankly, we're not to that point yet, but the very least, you start the team thinking about it, you start moving, again, baby steps, maybe even we as networks, you talk to your friends about how did you do this or how did you deal with that problem, and people develop sort of the consciousness and confidence to start doing these things.
Great. Thank you, Kevin.
Yeah.
Somebody has a question? No. Well, I really want to thank both speakers for great presentations on this very important topic. Thanks, Juliet, for providing the piece of information that we were missing on the webinar. Looks like our last webinar had a record number of attendance with 184 people registered and 80 participants, excluding the speakers and ISHLT staff. So that was quite remarkable. I see Juliet, Nikki, and Greg from ISHLT. I don't know if any of you wants to highlight anything or any important announcement before we finished our town hall today. Please go ahead.
Well, I'd like to thank you for stepping in for Alex at the last minute, and of course thank everyone in this community, all of the leaders and participants and contributors. As I mentioned before, ISHLT's roots are in surgery, and we want to. It's of course a multidisciplinary international society. That's our special sauce. But we want to honor and respect the roots and elevate the engagement of our surgeons in 2026. That's going to be a focus that we hear about a lot.
Fantastic. We'll work towards that.
Fabulous. Thank you.
All right. Anybody else has any comments? Otherwise, with this, we'll conclude our town hall. Thanks, everybody, for attending today. Thank you.